Okay, let's talk about cholestasis of pregnancy. All right. Okay, what's causing cholestasis? So it's thought to be hormonal, but there are genetic and environmental factors. In essence, it's a functional disorder of bile formation. And you'll typically see this in the second or third trimester. And some of the associated signs are itchiness or pruritus in the palms and soles. It's worse at night. You'll see skin excoriations from the scratching. And a portion of those will might have jaundice. Some important lab findings you'll get are increased alkaline phosphatase, increased aminotransferase levels, and this will be typically in the greater than 1,000 range. And you'll see this increased total bile acids and increased total and direct bilirubin. In terms of management, this should typically resolve after delivery, but you can also give ursodeoxycholic acid. And you would want to deliver early, meaning if once the fetus achieves a mature age, like 37 weeks, you would want to consider delivering to avoid any further complications. And by complications, they can be pretty severe, like fetal demise. You can also get respiratory distress syndrome. And then also just a word of caution to not confuse acute fatty liver of pregnancy with cholestasis of pregnancy. So this is something that I kind of got confused by. So fatty liver in pregnancy can also give you elevated aminotransferases, and there's an increased risk of fetal demise. However, you might not see scleral icterus or jaundice. You wouldn't get encephalopathy, and in that case, you could also see low platelet counts. So just be cautious of not confusing those two. Okay, let's talk about protracted active phase of labor. So this is going to be caused by the head being too big. This is also termed as cephalopelvic disproportion. And the people who are getting this are going to be people who are obese, people who haven't had a kid before, and people who don't have inadequate power behind their contractions. And what you will see with this is you might get a graph on the question showing dilation over time. And if you have a protracted active phase, you'll have a dilation that's moving less than 1 centimeter every 2 hours. When normally you should be dilating more than 1 centimeter every 2 hours. So I have examples of a fetal malposition that could cause this is if the baby is sunny side up, or more appropriately turned occiput posterior. All right, next topic is homocystinuria. This is caused by an error in methionine metabolism, more specifically the deficiency in the cystithiamine synthase, which I believe is right here. And this, you'll see this as an autosomal recessive disorder. It's relatively rare, but it affects both males and females in equal numbers. So the clinical features of this that are key to note are thrombosis. You'll get increased adhesiveness of platelets. You'll get intellectual disability. And you'll tend to notice that the people who have this are fair in skin color. And you'll get associated hyperelasticity and a morphonoid habitus, which is basically a tall stature, scoliosis, and pectus deformity. In terms of lab finding, you might see that they have megaloblastic anemia. And how you diagnose this is elevated homocysteine, and methionine levels. And your management will be giving B6, sometimes B9 and B12, and anticoagulation to counteract that thrombotic state. So that kind of makes sense in that, if you see here, this is thiamine synthase. If that's knocked out, you won't be producing your B6. And that could interrupt some of these other cycles too. And you might want to give B9 and B12 to help promote continuation of the cycle. So the key, also word of caution, is to note the intellectual disability and the thrombosis could be key to distinguishing this from Marfan syndrome. As you can recall here, you might have a Marfan-like features, like the tall stature, etc. So these two will kind of help you distinguish that, because you don't see that in Marfan syndrome. Also know about Ehlers-Danlos, because I got confused with this as soon as I saw hyperelasticity. I was thinking Ehlers-Danlos instantly. Just be careful not to confuse that. Ehlers-Danlos, you won't have all the plethora of things that is associated with homocystinuria, so you wouldn't have a thrombosis or intellectual disability or the tall stature. So again, anything that's mentioning a thrombotic event, for example, like a stroke in a kid with associated intellectual disability and it's really tall, you want to think about homocystinuria. Okay, next, anterior cord syndrome. So this can be caused by either trauma or occlusion of the anterior spinal artery. Now this, what you might see on physical exam is you're not going to get pinprick or temperature sensation, but you will get vibratory sensation below the level of the injury. And you'll have paralysis below the level of the injury. So in this picture here, this person wouldn't have movement in their legs, and thus also can disrupt bladder control. So you could have urinary retention here. And how to confirm this is by MRI. And in terms of some management, that might be important for the bladder symptoms is catheterization. So you want to prevent the urinary retention that could happen. Okay, let's quickly talk about hiatal hernia. Now this is when the top of the stomach, or the fundus, and it slips through this opening where the esophagus meets the stomach into the thoracic cavity. Now you might get nausea, dysphagia, chest pain, so kind of all the hallmarks of something like GERD. And how you're going to confirm this is you could see air fluid levels within the chest cavity. But to confirm this, you can also do a barium swallow or upper GI to confirm that. There is a risk of volvulus with this. Again, the symptoms are very similar to GERD, but the imaging will clue you in and kind of showing you that there's air in the chest cavity, which is a normal, so you might think about hiatal hernia. Okay, next, intestinal malrotation and volvulus. So the people who are gonna get volvulus are the kids who have an existing malrotation or risk for malrotation, such as a kid who had an bowel seal. And some features of this that you want to think about are bilious vomiting, and you could get signs of ischemia later on and then eventually shock. To confirm this, you're going to do an upper GI series, and then your surgery is going to be a LAD procedure, which fixes the bowel so that it's not going to rotate in the future, hopefully. And then, so a little bit know about malrotation and volvulus. I was kind of confused about the difference. But malrotation is kind of the state that you're in, and when you get symptoms from that state, that's when it could become volvulus or some obstructive pathology. And also note to not confuse this with reflux, which is common in children. And the key thing of that is the bilious vomiting. So you wouldn't see bilious vomiting in a kid normally. This should clue you in that something serious is happening. So anytime you get bilious vomiting, you're going to think volvulus. You'd also think duodenal atresia. If the kid is really young, like just a few days old, Hirschsprung disease you could think about. But yeah, you should think about something serious. Next, diaphragmatic rupture, which can be caused by trauma. I think there's a congenital form as well, but we'll just be talking about the trauma. So the clinical features, you get abdominal pain, shortness of breath, vomiting. And the x-ray will clue you into this. You'll see these darker opacities, which indicate air in the lung cavity. CT will be more sensitive for this. So if you get a question that's like, we already did the x-ray, what's the next step? Do CT imaging to confirm. And also why you do that is with children, you might not have the symptoms right away and could present with some more serious symptoms later. So do the CT imaging. And then one thing to note that I did wrong is confuse this with the hemothorax, which should appear as a fluid collection. So that's going to be a whitish x-ray. And the difference here is pretty obvious, but in some of the questions I got, it's less obvious. Like the air in the chest cavity is more vague. So just take a careful look at it and think about the context of the problem.